Happy Friday. So nice to see you all. We're going to give folks just another minute to join. It is Friday, and whether they're coming from another call or starting their day a little later, or running from building to building, as some of our providers are doing these mornings, we're just going to give folks a minute to join us. But good morning. Thank you for joining us and for being so generous as to give us 2 hours of your day today. We know we're going to get a lot done, and we hope we have integrated all of your feedback on how to best have a fruitful conversation today. So if I can have you say hello in the chat box and tell us what you see outside your window, just so we can start to imagine what everybody's world looks like right now as we have people join us. And I see some new names in our audience, so welcome. If this is your first time joining the Maternal Health Task Force, we are delighted to have you here and to have you be a part of the group. And if you are brand new to this group and this is your first time, we would love to have you go to the chat box and say hello and introduce yourself. Let us know your name, what part of Massachusetts you might be calling us from today, and your role. I think by now I've considered you all basically part of the a big family. So Maeve, welcome to, or Mava, please let me know how you say your name. Welcome to our team.
Hello, I'm so sorry. I was having some sound issues and I couldn't hear. So I missed what you said at first, but I can introduce myself. My name is Maeva, and I am a healthcare analyst at the Attorney General's office, and I'm very excited to be here with you all, folks who care very deeply about this work, which has me so pumped and excited to be here. So thank you.
Yeah, we're happy to have you. No worries. Sound, Zoom, one day we will all just work with it perfectly. Let's see, the chat box is moving a lot faster than I can keep up with it. So any other new members that want to say hello and introduce themselves, I welcome you to take yourself off of mute and come say hello to everybody. I love how many of you have herb gardens or gardens. We have like our own little pull up and share vegetables. Well, glad to have you here. Thank you once again. I'm just going to go ahead and get us started. And if you just had a minute, if you're just joining us, please take a minute to go to the chat box and say hello. Let us know what you can see outside your window and where you're calling us from in Massachusetts. And we will get our call started today.
Z, I tried twice. It's still cloudy in Norwood.
It's very cloudy in Pembroke, so look very sad. All right, I'm gonna go ahead and get us started. My name is Sandra Levesque. I have the privilege to be one of your facilitators for this time, and I'd love to just take a minute to let you know that in addition to myself and our team at EDC, we have my colleagues, Mary McCrane, who is our Director of Maternal and Child Health Programs here at Education Development Center, as well as Christy Reardon, who is one of our project directors in our early childhood portfolio too, and who many of you have seen, and then you know Carol by now, who have the privilege of being able to facilitate this call with you, for you and with you today. All right, so I see our numbers are started to slow down. So just some friendly reminders as always. If you join by computer, our breakout rooms will go a lot smoother for you. So take a minute to do that if possible. If This call, this group is all about contribution and sharing your thoughts and a discussion. So because of that, you get to mute yourself. So if you ever hear any background noise, check your mute button first so that we can get rid of it. And that means that we want to hear from you. So please come off of mute. Don't let technology be the reason we don't hear from you. Use the chat box for any tech support. Both Denise and Anna are happy to help you throughout the call. And also, that chat box is yours to tell us what you're thinking, to respond, to react, to ask questions, if that is your preferred way of reflecting and processing information. But again, don't particularly love listening to myself or each other, like us facilitators the whole time. So please speak up. And all decisions and notes, by now you know that they get sent out about a week after the call, and they all get linked in our bulletin board where you can have access to them afterwards. If possible, I'm going to welcome you to turn on those cameras, turn them on, turn them off as we go through the meeting to allow yourself to have some space for care, drinking water, eating breakfast, whatever it is that you need to do. But it does help us feel like we are a bit more connected. And, you know, in place of having the privilege of being in person, those cameras help us. Okay, we are in our fourth meeting, which feels a little wild that we have had about 5-6 hours together to get to know each other. Just to remind us all, we spent the first 2 meetings really learning about what are the current and ongoing strategies and efforts that are happening as a result of this Maternal and Child Health Bureau investment. But also we've learned a lot about the commission report recommendations that we hope guide the work of this Maternal Health Task Force. The last time we started to think about what are those strategies that will be part of our strategic plan. And today we're going to really dive in and do some of that work. Throughout this entire time has been our intention to create spaces for you all to connect and get to know each other. And so though we are not spending as much time on that today, we know that the small breakouts will allow for that organically. So what are we going to do today? We are going to engage in a discussion and small discussion. You told us that's what you wanted, and you wanted an opportunity to go really deep into the conversation. So that's what we're going to do. We're going to have breakouts, and a good portion of today's call, about an hour, will be dedicated to talking about those strategies. We are going to discuss in those groups what are the gaps, what is feasible, what is impactful, what is going to help us throughout the next 4 to 5 years to achieve systems improvements across our Commonwealth. And we are going to continue to assess and ask ourselves, okay, in light of the conversation we had today, who else is missing? Who else do we need to bring to this group? This question has allowed us to extend invitations to additional folks. And so that's what we're seeing, new people every time that we come together. And that just brings richness of thought and richness of contribution to our work. So how does this sound to you all? I think by now we know I'm a big fan of those reaction buttons, or just to see you. So please let me know with the reactions, the emoji things, how you're feeling about it. You can go into the chat box and tell me how you're feeling about it, or simply I can see your faces. So you can also just give me a thumbs up, or say hello, or smile, or whatever you got. Great. All right. So how are we going to achieve those objectives? We are going to achieve those objectives by starting first with a conversation about systems improvements. We are going to hear from members of the task force, being just very grateful to Nicole, Danette, Anne, and Stephanie, who will introduce themselves in a bit, who are going to tell us a little bit about, from their perspective, what are positive examples of systems improvements and maternal health, but then also really start to help us think about where are our failures and what are strategies that can help us make those systems changes that will result in population level change. From there, that's going to set us up, we believe, to go straight into our breakout groups. And so you're going to join myself, Mary, Christy, and Carol into small groups to really have a deep conversation about each of the strategies. And these are going to be facilitated conversations, but really a space for you to bring your expertise, your knowledge, your experience, your questions, and your curiosities, and your innovative thoughts too. And our promise to you is that we're going to capture them so we can organize them. And we know that today we're asking you to pick one strategy to contribute to, but that doesn't mean this is the only time you have an opportunity for contribution. So do not worry. We'll do that at the heart of our call, and then we'll summarize and wrap up and let you know what we're going to do over the month of August to bring you back in September. Okay, So our discussion today is going to be organized by the 4 themes that this group agreed to during our last call. And that is that in order to achieve maternal health equity in the Commonwealth and to really make advancements, we really need a highly skilled, culturally responsive, and trauma-informed perinatal workforce. We need community linkages, partnerships, and strength. We need high-quality perinatal care that advances racial equity, and we need an infrastructure that achieves racial equity. So these are the 4 breakouts. So I'm going to ask you to head on over to the chat box, and I'm going to ask you to complete that very brief survey, like I'm talking like a poll, that Anna is going to put in the chat box. And I want you to tell us which of these you are most ready to contribute to today, your first and your second choice. So based on your experience, your expertise, and how you're feeling today, because that matters, which of these do you feel you are most ready to contribute to today? And then we snuck a question in there that's asking you how you're feeling, because the energy that we all bring to these calls impacts the conversations we have. So go ahead and answer that brief survey. And once you're done, just check in with us. I'm going to put a note in the chat box that says, I'm done. And I'm going to ask that you heart it, like it, give it a thumbs up so I get a sense of when everybody's complete. I have about half of you saying you have completed it. We'll give you another 30 seconds and then we're going to move on. What's going to happen in the background is Anna is going to take that information and she's going to build out our breakout groups so that we have good representation across our 4 topics. And if all of you, bring incredible expertise that crosses all those various themes, so not to worry, I'll just say it again, you will have an opportunity to contribute to multiple of those in the coming months. All right. Thank you, Anna. Okay. So while that's happening in the background, I just want to ground us all in our group agreements. The conversations that we have here are personal. We have the opportunity in this space to share our passions, our lived experiences, our ideas, our opinions, our thoughts. And with that comes being able to do that necessitates that we have a place where we have respect, where we foster a place for sharing, where we don't have judgment, where we assume good intentions. And so the community agreements that you see here on the screen are yours. This is what you've told us that you need in order to feel like you can contribute in this space. So we're going to just give a space here to acknowledge joy, to assume good intentions, to really lean in on each other, to leverage the power of collective healing, to being honest, to ensuring that we create space for one another, that we minimize the use of jargon, and that we create language that invites all to contribute. And that we really challenge ourselves to think about how we do this work differently. In quality improvement, we say every system is designed to get the output it does. So I think there is consensus here that if we continue to do and provide services the way that we are now, we are going to continue to see the outcomes that we're seeing now. So let's challenge each other. Let's support each other to think how we might do things differently. So as you know, I'm going to ask you, can you sign on to these community agreements? And please let us know if there are any that are missing for you, and just actively say, I agree to these community agreements and to these values and principles. Great. Thank you, everybody. You all are fantastically attentive during these calls. Okay, so let's bring us back to why we're here together. We're here to create a strategic plan together to improve maternal health in the state of Massachusetts. We are being intentional to not duplicate, to not recreate the wheel. We are intentional to build up from our Title V efforts, the Maternal and Child Health Block Grant Title V efforts. We are being intentional to lift up and build on our report of the Special Commission on Racial Inequities in Maternal Health, and the work of our maternal mortality and morbidity review. And together we have said we are going to use the expertise, the knowledge and experience of every person here and put forth a strategic plan that can lead us to systems improvement and ensure that every pregnant person, every person who gives birth, every postpartum person in every family has the opportunity to have access to the highest of quality of services and lead a full life. So with that, knowing that that's what we're after, improving systems, I want to just ask you a brief warm-up question and ask you all to think about a time where you saw effective systems change, where something changed for the better. This doesn't have to be related to maternal health. So I'll give you an example. Smoking. Smoking in the United States has gone through tremendous improvement. So go to the chat box and tell us, share with each other. What is an example of effective systems change where you saw that there was effective systems change, where something has changed for the better? I see helmets, I see seat belts and car seats. Now, it's intentional that we say for the better, because nothing's perfect. So every system requires improvement. So immunization, eat, sleep, console. Seat belts, car seats, and smoking. What are your thoughts? Yeah, those are most typically the ones that people think of. Great. Healthcare coverage for almost all. Approval for over-the-counter birth control pills. These are great. Reduce sudden infant death syndromes. Yep. Back to sleep. Yes, great. Thank you. So we're asking you this very brief warm-up question as a way to transition us to invite members of the task force to share more discreetly what are system efforts in maternal health that have allowed us to improve and make advancements. So with that, I'm going to invite Nicole, Danette, Anne, and Stephanie to come on camera. And everybody else, this is going to be a conversation. We're just want to start really warming up our minds and shifting our mental model to before we enter into those conversations about what is the possibilities that we have as a maternal health task force to really advance systems improvement. And so I'd love to welcome you all. And I believe that Anna's probably going to spotlight them so that you can see and wonderful panelists and peers. Would love it if you could say your name when you first answer your first question so people can get to know you a little bit more and your role. So I'm going to start with, let's start with a conversation with an example of a positive systems change in service of advancing maternal health. And so Nicole, I'm just going to turn it over to you, see what you'd like to share with others.
So my name is Nicole Lamerson. I'm a researcher at Brandeis at the Lurie Institute for Disability Policy. And in the interest of full disclosure, it took me a long time to think up a systems change in maternal health that is working or is positive for my population of disabled people. And ultimately where I settled is that we are finally collecting data about the outcomes and experiences of pregnant birthing people and the experiences of disabled parents in Massachusetts. And we cannot fix what we do not know. So we have to collect the data to fix it. And that's where I landed in terms of data in Massachusetts. We're collecting information about disability on PRAMs, pregnancy risk assessment monitoring, also on PEL, which is the pregnancy early life longitudinal study. So we're collecting data. And my group believes that enough is known to act. That's why I'm here.
Thank you, Nicole, for sharing both how hard it is to think of a positive, and then also for lifting up what maybe sometimes we don't appreciate, such a large contribution and advancement in the field. So thank you. Stephanie, I'd love if you could share your perspective. And if you could please introduce yourself too.
Sure. I'm Stephanie Crawford. I am the founder of a nonprofit that works closely with families that have experienced pregnancy and infant loss. I'm a full spectrum doula and an early childhood educator. So I come from different perspectives. I think I struggled a little bit too to think about something. And so I kind of went a little personal, but personal in terms of for me, but also the families that I'm working with. And I would say, the conversation around pregnancy and infant loss is very different today than it was 12 years ago when I experienced a stillbirth. I think when I experienced a stillbirth, I had no idea that it could even happen. After a certain stage, I was kind of like, whoa, I thought I was safe. I didn't know what to do, what was going on. I had no, the resources were very slim. The hospital that I gave birth in was like, we have resources, but next year, like we do this event, but it's next year. And so I think that the conversation, the initiatives, even down to the opportunities that I have in my nonprofit to present like free programming for families. It was really hard to get free programming into families years ago. And so now the conversation is open a lot more. Even legislators are talking about it. There's different campaigns. And so we're not where I would love us to be, but there's definitely positive change.
Thank you, Stephanie, for sharing so much about yourself and just your reflections over time. It struck me that we're talking about a non-existence to increase awareness to now you calling out how people in power now know about this and the opportunity that we have to make policies and programs available to all families. So thank you. And I'd love to give you a chance to introduce yourself and share your perspective.
Hi, everyone. My name is Ann Peralta, and I work for the Department of Public Health as the Division Director of the Pregnancy, Infancy, and Early Childhood Division. And the one that came to mind for me is definitely in progress and still promising. But I think I'm really hopeful and excited about it, which is the shift that we're seeing across the country and in Massachusetts for payer reimbursement of doula services. Right, there was no system. It was all private pay, and still is right now in Massachusetts, almost exclusively. There are a couple little exceptions, but exclusively private pay, which sort of left this chasm of either you're a private doula serving, pregnant people with means who can pay you like reasonable amounts for your work, or you're providing your services for free to people who can't afford that. And there's very little in between, and still is. And so while they are not perfect, and there's plenty to get wrong in these efforts, I'm just really excited about building a system and getting it to improve over time that provides a mechanism for payers like our colleagues at Mass Health to provide a mechanism for people without the means to pay private pay rates for doulas to have doula care, which we all know is so impactful. So it's already existing in some other states. Again, not perfectly, but we're working on it. And I'm really excited that that's coming to Massachusetts, because that's a really, a system where one didn't exist.
Thank you. And I love that you are, I think everybody, the running theme so far is this idea of these system changes are not complete. They're not perfect, but they're a starting place. And once you have a starting place, you have an opportunity for improvement, but at least it is now part of the conversation. And I appreciate that in your example, you're really showing the power of those baby steps, that incrementalism. We start, we go, and we advocate over time. So Danette, we'd love to, please take a minute to introduce yourself. I'd love to hear your perspective on an example of a positive system change.
Hello, good morning, everyone. Well, I am Donette McManus. I am a biological mom of one, but also a mom of four. I have lived experience from both the perspective and lenses of myself, as well as the lenses of my sister, who has passed away in 2019. I am advocating for change because I believe that my sister's voice was taken away, and I want to give her voice back, um, in the form of advocacy, in the form of just letting the system. I don't even know how to say it, because I always say they, but I don't even know how to define who they are. So I want to be able to give a voice back to my sister and to others like her. I think that there are lots of positive changes happening. So for example, when my son was born, I had my son through IVF, and I had hemorrhaging fibroids. So my prognosis was, you basically can give up on having children because you need a hysterectomy in order to stop the bleeding. It was just like, this is what we are going to do because this is what is going to save your life. But little did they know that I wanted to be a mom more than anything else in my life. So by taking that right away from me, I would probably be losing my life. So anyways, I had to basically go out and advocate for myself and find resources. And fast forward to now, there are lots of resources available for women with fibroids. There are lots of resources for women who have difficult situations that they have to walk through in terms of their reproductive health. And you just have to find them. So my goal is to give voice to finding the resources and bridging the gap.
Thank you, Danette. I think, thank you so much for being here, for sharing your experience. And I think you're also highlighting what your colleagues have shared is we're seeing a shift in knowledge and awareness and in mental models. And yet, despite that improvement, it is insufficient, the access, and it's insufficient that our systems are not designed for people to be able to reach them and to know about them. And so that actually your answer leads us to the next place, which is there is much to celebrate in systems improvement, but we also know that our systems are failing people who want to get pregnant people who give birth postpartum, and their families. So I'm going to go over now to Danette. We'll start back up with you, which is if you wouldn't mind sharing an example of a way in which the system has failed, and then we can hear from everybody and then start thinking together about strategies.
Well, one of the ways that the systems failed, especially failed my sister, was that they did not hear her. She went to an example of this is when she went to her physician, her high-risk physician that was supposed to be trained in maternal health. Her physician basically told her, the date that you're giving birth is August 5th. This is the date. And everything all of her care kind of revolved around the date that you're going to be giving birth. And so they didn't hear what she said when she said, my baby's not going to be born in August. My baby's probably going to be born in July. I have 2 other children who were born not when the physician told me that they were going to be born, but when I know my body is telling me that my babies are going to be born. And as a result of that, she wasn't heard up until the day before she actually passed away. And the day that they actually heard her, August 5th, 2019, was the day that I laid her body to rest. So not hearing my sister, not hearing her voice, not hearing when she said, I'm in pain and there's something wrong, and them telling her to push the pain medication button, push it, and it will activate medicine to help you, versus them helping her and hearing her so that they could prevent what happened to her.
Thank you for sharing your experience and your willingness and your vulnerability to share more of what you and your sister lived through. And I, Danette, when we were chatting in preparation for this, something that strikes me is that you're lifting up how that system is designed to move around protocols, procedures, and dates, and not designed to be centered in the humanity of the people who are pregnant, who are living, and who can tell you exactly what their bodies need. So, we're thinking about systems like that is so striking, that is true for so many. And so, Stephanie, from your perspective, as from many of your lenses, I'd love to hear, how you would say that the systems are also failing us in maternal health.
I think I would say that although like the spaces are more available and, there's more conversation, there's not a lot of spaces where the people that are actually experiencing these things are in the conversation and are able to have a part in the change. I know a lot of people come from my experience working with families and obviously having this nonprofit, right? Like you come out of a loss feeling like, okay, I need like what is my purpose? And usually your purpose is around a change, something specific that happened to you that you don't want to happen to anyone else. And I think that, and Donna, if I can say that you're saying the same thing, and I think we all feel that. But then if you don't have the right avenues or the right connections, you end up not really ever being able to make impact or input and find, fulfill that purpose because you don't have that space. So.
Thank you, Stephanie. And it's that there's just the commonalities on what Danette's sharing and what you're sharing is we have these experiences, but the systems of people making decisions and people making these protocols don't have, even if they wanted to, they don't have an opportunity for that connection. And we know that there are many that do because they're here. We have so many providers and so many representatives of our public health and healthcare systems, but that connection doesn't exist. And with that comes also thinking about accountability when those systems fail, what level of accountability there is. So I'd love to hear from you, Anne, about ways in which you think that the system is failing us.
Yeah, and thank you both for sharing your perspectives. What came to mind for me as a respectful maternity care is a huge passion area for mine, and things like shared decision making based on my own experiences, albeit with lots of privilege, but still not what I thought should be the kind of care and decision-making involvement that I should have. And I think what I've come to understand and think about and try to work on is we have this collection of guidelines and interventions that are often like there aren't any systems that go along with them. So for example, there are ACOG and ACNM, all these clinical big bodies of recommendations, but then there's no system of accountability for them actually getting implemented. And they're just guidelines, right? So, and at hospitals, often hospitals also have guidelines suggesting these things, but there's no teeth or accountability or mechanism for like, this isn't actually happening. So there's lots of great calls for things, but then no system of widespread implementation, tools to actually make that happen. And I feel like one of the widespread responses is implicit bias training, but clearly that's not cutting it, right? There's no accountability after those. Is like, you went to the training, but did anything actually happen? Is your practice different now? What is the experience of your patients and your colleagues and the doulas that walk in to your room? And I think there's so much opportunity there, but right now that is a failing system of just, and what end up feeling like empty guidelines and recommendations because of the lack of, it's just sort of an opt-in. If you happen to be like an incredible individual or individual institution, you do something about it, and there's no repercussions if you don't. For you, there are repercussions for all of us if they don't, just to be clear about that.
Yeah, thank you, Anne. And I, so far you guys have so much talked about the impact that these systems have on the person receiving the care, or the families receiving the care. And but also we know that the actual physical design of these spaces are also not serving families. So Nicole, would love to hear from you about how our systems physical designs are not supporting families.
Yeah, I just want to very quickly mention that when I talk about disability, race is baked into that. People of color, Indigenous people, Black people are more likely to be disabled in this country than their white peers. And yes, physical access is a huge problem. I would say one way we're failing is the Americans with Disabilities Act has been the law of the land for 33 years now, 34. And our hospitals, our doctor's offices are not accessible to people with disabilities. I hear this every single day, over and over. I go to a physician who is wonderful, a primary care physician. I can't get on her exam table. There is no mechanism to enforce physical and, even more importantly, attitudinal access in the treatment of disabled people, especially in the treatment of disabled birthing people of color. There is no mechanism of enforcement of the ADA or a previous law that's 50-some years old that ensures that doctors will treat disabled people with the respect and care that they deserve. And honestly, I'm a survivor of severe maternal morbidity. And I believe the only reason I am alive today after surviving a very severe Accreta that was undiagnosed was that before I went in for my cesarean section, I sat my doctor down and I said, I've never met you, but I have a disability and I have excellent quality of life, and my life is just as important as that baby's. And I absolutely believe that contributed to him working as quickly as he did to save my life. But we need mechanisms to enforce accessible care.
Thank you so much, Nicole. I think sharing so much, all of you, for sharing so much about who you are, how you show up, for the work that you do, and the advocacy that you do every single day. We know that we have made advancements. You all have made it clear that those advancements are incomplete, that it is not sufficient, nor is it appropriate to have the expectation that individuals take that on, but that really we need to challenge our full systems to do that. All of your comments have also really lifted up how important intersectionality is, understanding that we are not, I'll speak from an I am not just a Hispanic woman as assigned by the census tract, so that we have experiences that all of us and our interactions in the places that we live really matter. So I want to go all the way around here and then move us. We have successes, we have failures, and you guys said it, I believe Nicole and both Danette said it, like, we know what to do. And large part, we know what to do. So I'd love to go over to you, Nicole, and say, share with us. There are many strategies. So we wish we had all the time today to talk about all of them, which we will in a minute. But if you could share with us one strategy that you think can make an impact at that systems level.
Yeah, and what I hear over and over again from disabled people is that providers need education on this, on disability, and how to treat disabled people. And I strongly believe that when we're looking at DEI efforts, disability must be included, and some kind of disability training that is meaningful and baked into all areas of medical education should be required for accreditation. I am at that point. Like, this has been going on too long. And this is the same, I feel the same way for all other DEI efforts, but disability must be at that table. Right now, the way I'm helping people solve things is I am a one-woman island with disabled parents calling me every day, asking for help. And I'm doing grand rounds. And every time I do grand rounds, a social worker reaches out to me. Last week at Beth Israel, in the spirit of remembering joy, last week, a social worker at Beth Israel reached out to me and she said, "Hey, I heard you talk once, and we have a mom who's a paraplegic and she's going to deliver next week. And I don't want what happened to you to happen to her. How do I fix this?" And and that's not the first time that happened. That's just the first time that week. And, but I can't keep doing this as a one-woman island. I can't.
Thank you, Nicole. I know we can't clone you. So we need systems that are able to do that, to honor those values. So Anne, what about you? What would you offer as a strategy?
One of the things on the topic I brought up of what are accountability opportunities for things like respectful maternity care is I'm really excited that a Black-led organization called Reproductive Health Impact, formerly known as National Birth Equity Collaborative, if they just changed their name. So anyway, if that helps you place them, I know they're working with the Centers for Medicaid and Medicare and another one of those agencies that I could tell you the acronym, but I can't remember what it stands for, but federal level agencies, they're working with them on a patient reported experience measure with the goal of baking it into payment, like standards of quality and payment mechanisms. And I am just so excited about the fact that that's their goal. It means compromises. It means it's not going to be perfect. It means it's really annoying and there's lots of barriers. But that would be a way, an example of how you build that into the systems that are paying, as Darlene is saying in the chat.
Stephanie, what about you? What a strategy might you offer?
Yeah, I think we talked a little bit already about like co-creation of policy. And I think, people with lived experience, bringing them to the table is really important. But I think also I might add that like there are community organizations, grassroots organizations that are meeting with these people every day that can help people find their voice or can bring the voices together and present them. And I think also bringing those organizations and people and and just like really tapping into the community when creating policies and programs and making change.
Thank you, Stephanie. And Danette, what about you? What is one strategy you would offer
Hmm.
to our systems?
Okay, one strategy that I think I'm going to borrow the term baked into women's health would probably be case management services. So, in my experience, every time I've gone to a provider, there's been some person, whether rolling in on a cart with a laptop that says, "What are your insurances? What, where do you live? What's your job?" etc. That person, too, could use that opportunity to provide case management support. And maybe it could just be as simple as you're here today, you're seeing your physician for your follow up care. What other services might you need in order to be well? And that could mean providing resources, a list of resources, or or connecting you with people who will call you and say, listen, we heard that you had a visit. We heard that you have, I just was at a conference, so this is on my mind, food insecurity. Here are some resources for you. Here's a list of local food banks. This is what um, if this is what you need, we're here to provide you with case management services to help you be well. And maybe also have that case manager like follow up and be that one person that's kind of bringing the team of resources together for you so that you don't have to navigate it for yourself.
Thank you so much, Danette. As many of you know, when we introduce ourselves, that just makes me think of the incredible opportunities we have in Massachusetts with our home visiting programs, with our perinatal services, and the opportunities to really connect people from healthcare to community, and making sure that all the points that you all made today, which is it should not just be on the person having to seek, to manage, to access, to negotiate, but rather it should be accessible, it should be open. And what I want to say is all of you, first of all, thank you for your incredible thoughts, for being your willingness to share. All of you have so perfectly outlined the various systems that need to be addressed. And not surprisingly, those line up with what this task force agreed to needs to be improved. So our workforce, our infrastructure, our quality of care, and our linkages to communities. So this seems like the perfect transition point to say, we just got left with some ideas, but there's many more. So let's talk about the feasibility and the impact of these many other strategies that are coming up. So thank you. I want to welcome everybody that just had the privilege to listen. To please share your reflections in the chat box, whether that is a thought of gratitude for our panelists or whether that is something that came up for you. Please go over to the chat box and let us know how you're feeling. And while you do that, we are going to go ahead and transition over to our breakouts. So what is going to happen in our breakouts is we're going to use the large portion of our call, about the next hour or so, to have a conversation. Each of you at the top of the call told us that you had a preferred topic to start contributing to today. Anna in the background has been able to assign you all to these groups, and you're going to be taken away into there. If you don't, and you need a minute or a moment to be helped, please stay put. You'll get some help to go to the right room. And in there, you'll have some of our facilitators who are going to put up some Padlets. And those links are there. Don't worry. Those links will come to you in the chat box in your breakout groups too. And we're going to have a conversation about them. So to put us into the right rooms and just check in with you. Does everything, how are you feeling? Does that make sense? So we're going to now go into the conversations and the discussion. I see a lot of nods and smiles.
I have a quick question. Will I just automatically get moved as well?
Yes, everybody is going to magically go into your spaces.
Super.
All right, so Anna and Denise, go ahead, please, and please enjoy your conversations, and thank you for your hard work. Hi, all. I think we may have had just a little bit of an error in communication that we're not supposed to be disbanded, but rather have an opportunity to make sure everybody had a break. So Denise, I'm going to ask you to put us back and to allow the conversation to keep on going and support our facilitators to manage their breaks on their own.
Sure, I'm sorry, I misunderstood what you.
That's okay. No worries.